Welcome back, everyone. I'm so excited to talk to everyone about Delirium today. When we talked last presentation about the ABCDF bundle, the incredible improvements to outcomes that it has for our patients, it really requires a deeper dive into what Delirium is and why it is so impactful to our patients with their short and long-term outcomes. And obviously we've all heard the term delirium. It's something that a vast majority of our patients suffer from. Up to 81% of patients in the ICU suffer from delirium. But sometimes I think the frequency of it, the normality of it, gets interpreted as benign, like it's transient, acute confusion, and that our patients will recover from it on the floor or an LTAC and move on with their lives. That's often not the case, and we're going to talk a lot about that. What we think of when we think about delirium is usually the hyperactive delirium, when they're trying to pull out their lines, self-extubate, pulling out their restraint, trying to get out of bed. That is obviously florid delirium. We can really see that, and we then diagnose it. But only 33% of delirium is hyperactive. 44.5% of delirium looks like this: hypoactive delirium, when patients are difficult to arouse, they seem lethargic, they have severe inattention. Yeah, ironically, this picture right here is what we've been culturally trained to think as safe, as acceptable. The ultimate goal is to have patients look like they're sleeping, they're not moving, their lines and tubes are all in order, and this looks and feels comfortable to us. But what oftentimes is happening is that patients are having hypoactive delirium. And then there's a mixed delirium where they can fluctuate between hypoactive and hyperactive, or in and out of delirium. So you can have patients that you can barely get to arouse when you talk to them. When you come in, you turn your back to mixed meds and suddenly they're trying to crawl out of bed. That can be very challenging, obviously, when you can't predict and can't control their presentation. But this presentation of looking like they're asleep is rarely what the patients themselves are experiencing. And I think this is what our side of the bed really lacks, is the patient perspective, because many of our patients can't tell us what they're actually experiencing. And even once they're extubated, they're not able to articulate yet what their experience was under sedation while we thought that they were sleeping.
I went from a series of nightmares to nightmares. Never wake. In most of these nightmares, I call them, I know I'm sick, and I know I'm in a hospital bed, but it doesn't really matter because I'm in Boston on Christmas morning in the 1800s, and I'm kept at the harbor with a group of, I guess it would have been plague patients. And on that Christmas morning, they burned everyone in the harbor. I was in Oz one morning. Woke up, looked like the middle of Nebraska, but outside the door was the yellow brick road. And the folks I was staying with said, "You need to get on that road and you need to go." And even though there wasn't a tree for miles, there were leaves blowing through the air, and the sky was an orange-gray color, and they said, when the wind stops blowing and the leaves die down, the wizard's going to see you and he's going to kill you. And I literally believed that's what was going to happen. I watched my son die twice. I watched my daughter die 4 times. One time I caused her death. I think at last count I can remember 22 of these. I think one of the things that would have helped a great deal at the end was if anyone would have come into my room shut the door, sat down and said, okay, I know where your body's been for the last 28 days. Where have you been? And I think I would have told them at that point, because that's a clear signal that they understand what you're going through. But, you know, you folks are on the cutting edge of, I think, something really incredible. If you can keep what I went through down or eliminate it for other patients, you are angels. It is God's work. I went.
It was in late 2009 that I became one of the early swine flu victims, which rapidly progressed to severe ARDS, and put me on ECMO in an induced coma for 4 weeks. During my coma, I was trapped in a world of continuous, vivid and terrifying nightmares, some of them recurring, that would become my reality over the following weeks. There was no peaceful sleep or feeling of serenity. It was just visions of pain, torment and general mayhem. One nightmare which troubled me for a long time after recovering was the kidnapping of my 2 young daughters, aged 12 and 13. I would be tracking them down and get close to finding them, arriving at some building or house, only to discover they had been moved on, and I would always be one step behind, and this scenario would just keep playing out over and over. The feeling of despair and hopelessness in this nightmare was real, because I believed I would never see my daughters again. After waking from the coma, the nightmares I experienced carried forward. While lying in my ICU bed, paralysed and unable to talk due to the trach, I'm believing I will never see my girls again, as that was my reality in the world I inhabited during my coma, which was more real to me than the world I was now awake in. It was only when my daughters visited me 2 or 3 days later that I was released from that scenario. I was in tears seeing them walking through the ICU entrance doors towards my bed, and I tried to cover my face with a sheet of paper because I didn't want them to see me crying. I still clearly remember them asking their mother why I was crying, but it was tears of relief because I now knew they were safe. Another vivid nightmare that carried forward involved me being in hospital when gunmen started attacking the building. I was hiding from them until I was discovered, and then they started chasing me through the corridors and shooting at me as I ran in fear for my life. And I felt the bullets physically hitting me and entering my body as I fell to the floor dying. Again, when I woke from the coma, I thought I was in hospital being treated for gunshot wounds. This had to be triggered by the assault my body was under through medical procedures being performed on me. Neck and groin cannulation while on ECMO, tracheostomy, chest drains being inserted on both sides, which is where the bullets were hitting me. I also had many extreme nightmares that I can't talk about, as I am too ashamed and embarrassed that my mind could conjure up such imagery. But waking from the coma wouldn't be the end of it, as I now entered a world of delirium and experienced a distorted reality driven by auditory and visual hallucinations. What I was seeing and hearing was creating a lot of anxiety, and I became paranoid and mistrustful, and I could not be persuaded that I was safe and what I was experiencing was not real. Several of the nurses and doctors involved in my care entered into my hallucinations in a negative way, making me very wary of them. For example, a doctor attacked me and beat me up doing kung fu. A nurse mistreated me by pulling me around by my NG tube, and I repeatedly heard nurses having sex at the side of my bed. And the first person I would see come into my line of vision, I knew it was them, and that affected how I interacted with them. There were so many delusions. By the time I was discharged to the respiratory ward, I was emerging from the delirium and slowly regaining clarity of thought. While there, I began to reflect on events during my time in ICU and realised that I had 6 weeks worth of memories of a life I didn't live. Alongside this, new memories were surfacing every day, and I was struggling to determine what was real and what was imagined. Though I know and understand these are false memories, I still have emotions attached to them due to the impact of their perceived authenticity. In the months following hospital discharge, I suffered a psychological fallout that would lead to me being clinically diagnosed with PTSD and receiving 18 months of weekly counselling, CBT and EMDR therapy to help process my memories. Nearly 12 years later, I can still recall the nightmares with clarity, and they haunted me for a long time after in the form of flashbacks and intrusive thoughts. It truly was a miserable experience. It was in
What we oftentimes don't understand, not only that patients are not sleeping and they're not having an absence of experiences or peaceful rest, but this delirium is acute brain failure. It is an organ dysfunction, an organ failure that is just as important and even deadly as any other organ failure. One researcher just made the comparison to me that acute brain failure or delirium is just as impactful as an acute MI, that we should consider delirium as an MI of the brain. And we'll talk about what that actually means, because that can take people back a lot, but there's evidence to support that. What we need to understand is delirium has many features to it. And this is why screening for it with a validated tool like the CAM screening tool is so important. Delirium is not just agitation, it's not just confusion, but it's disorganized thinking, fluctuating mental status, acute mental status changes, inattention, especially. That is the primary, most prominent and most common feature of delirium. Psychomotor disturbance. This is why RAS is really important to be accurately assessing for, and acute disturbance in cognition. And so in order to screen for all of those features and make sure that we're catching delirium, we really need to be using the CAM screening tool, because it looks for one, acute change or fluctuating course of mental status. So have they had a change from baseline? If not, they're automatically a negative. We've automatically screened for delirium. But if they are different from baseline, then we do a screen for inattention with the Save a Heart. And this is where I'm finding teams are not fully doing it, because I don't think we're oftentimes really trained on how to do a CAM score. Sometimes it can seem like it takes too much time, right? But if we're not doing Save a Heart, if we're not doing all these levels, we can be missing acute brain failure. And if they get more than 2 wrong to Save a Heart, then we look at, is the RAS anything other than 0? And if it's anything other than 0, then it's automatically CAM positive. If it is 0, but they still got the Save a Heart a little bit wrong, then we need to look at, do they have disorganized thinking? So acute change in mental status, inattention, altered level of consciousness, disorganized thinking. This is why we need the CAM screening tool to be utilized frequency. I think most protocols require every 4 hours, because the CAM screening tool is the troponin of the brain. We need to be responding to it with as much urgency as we would an elevated troponin. We need to be checking it at least as frequently as we check for the creatinine. And this is our only way to understand whether or not a patient is having acute brain failure. We would never go days to weeks without assessing for acute renal failure. So we need to be looking at it just as frequently and as importantly as we do any other kind of organ failure. Otherwise, when we think that patients are sleeping, they could be having undetected organ dysfunction and failure. Even under imaging, we can see this injury happening to the brain. When patients are having delirium, it can look like Alzheimer's. There's brain atrophy, there's white matter hyperintensities, there's reduced perfusion to different parts of the brain, there are abnormalities in the structures. This is an acute brain injury. Now, there are lots of causes of delirium. Patients come into the ICU, patients in the ICU have on average, I think, 11 different risk factors for delirium. There could be drugs. So this can be drug toxicities or drugs that we give, certain antibiotics or certain sedatives, which we'll get into, ears, eyes, or other sensory deficits, low oxygen saturations, infection, retention of urine or stool, a postictal state, underhydration, undernourishment, metabolic causes like sodium abnormalities and subdural hematomas. So deliriums is a little acronym to help remember some of those main causes of delirium. And so even when a patient comes in, I think sepsis is one of the most common risk factors that patients arrive to the ICU with. Just because the patient has sepsis doesn't mean that they're bound to have delirium or that there's nothing that we can do to prevent and or minimize the duration and severity of delirium. And we'll get into that. Patients have a lot of baseline risk factors for delirium. Higher age, alcohol use, being female, living at home, smoking, that increases the risks of developing delirium. Cardiac disease, cognitive impairments at baseline, pulmonary disease increase their risks of developing delirium. And then the environment that they're in, things that we do, if they're admitted to ER, if they've been transferred from another facility, if they're isolated. We saw this, obviously, COVID created what some called a delirium factory. We really locked people into a difficult environment that really increased the risks of delirium. Things like having no visible daylight, no visitations, physical restraints, and then their illness itself, the higher length of stay, fever. If they already have a higher Apache score, they're already sicker, risk of mortality. They don't have normal food going in to their system. The more lines that we have, more perfusions that we have going, if we have psychoactive medication, sedation especially, the more lines and tubes we have, all of these play into increasing the risks of acute brain failure. And this acute brain failure does not just resolve. Oftentimes when we have acute renal failure in the hospital, by the time they're discharged, their creatinine looks pretty normal, their kidneys are somewhat recovered. That is not often the case for our patients with acute brain failure. This acute brain injury can turn into a chronic brain injury. Patients with delirium are at 120 times greater risk of long-term cognitive impairments. This means that they can have a worse global cognition and executive function 3 and 12 months after discharge and even longer. They can have memory and naming impairments 18 months and beyond after discharge. This impacts their activities of daily living. It impairs their motor sensory function and increases their risks of falls, readmission to the hospital. I've heard from survivors, it impairs their ability to drive again. Their response time is so slow, they can't drive anymore. People in their 40s now cannot drive themselves to work and oftentimes cannot return to their careers, to the work that they had before, but they become disabled and they lose their identity, their quality of life, it's a financial burden on them and their families when they lose their ability to cognitively function like they did before. And some people can never live independently again. And much of that ties back to having this brain injury during their admission into the ICU and even the hospital.
Hi, my name is Carol. I was in the ICU for 35 days when my colon ruptured back in 2018. I was ultimately in the hospital for a total of 4 months. But when I was in the ICU, I was placed in a medically induced coma. I was not conscious when I was taken to the hospital because I was in sepsis. But my family was told that I needed to be in that coma so that my body could rest. My body needed to heal. I am here to tell you that I have since found out that I did anything but rest. During that period of time, because of the medications that are used to place you in that coma, I had very vivid, frightening hallucinations. At one point, I thought that I was kidnapped and I was being held captive by some criminals. I was in a hotel in my mind where a lot of criminal activity was taking place. I was scared to open my eyes because I thought if anyone saw me looking at them, I was going to be killed. All of that was so real. And that occurred because of the medications that I was given to be placed in that coma. I have been suffering since I was released from the hospital from brain fog. I can't remember a lot of the things that I used to do, and I used to do well. I used to be a computer geek, and yet when I got out of the hospital and my laptop was in front of me, I didn't even know how to turn it on. That brain fog can cause you to lose focus. So I'm not able to sit down and pick up a book and just read casually. I don't have the focus to pay attention. I can't sit down to watch a television show. I just am not able to sit still long enough to focus on anything. I could not remember how to do the most basic things. To this day, if I'm cooking and I'm trying to follow a recipe, I have a difficult time. If I'm sitting down to pay my bills, I have trouble writing out checks. I have trouble keeping up my checkbook. I was running a family business at the time. And once I came home from the hospital and started going over the paperwork, I just stared at this pile. It looked like trash to me because I didn't know what to do with it. So my family had to consider whether they needed to sell the business or not.
And some people are calling this a post-ICU dementia since it looks a lot like early stage Alzheimer's. Another phrase is sedation-induced brain injury. And it impacts not just our survivors, but their families as well.
After I was discharged home, it became clear that I had problems with my short-term memory, concentration, and speed of thought. There was a huge gap between my pre-ICU level of cognitive function and what I now had. With no obvious improvement within the first month or so, my GP referred me to neurology at my local hospital for an initial assessment. I was reviewed and passed on to their brain injury team, where I underwent an extensive memory evaluation. I was dismayed when told that my results scored below the bottom end of normal, and normal is a very wide range. I knew I had problems, but I hadn't realised the full extent of my cognitive decline. I spent around 18 months under the brain injury team as an outpatient, being taught coping strategies, many of which I still use today, as they are now embedded in my daily routine. I worked for a large government department and my job was held open for 20 months, but alongside my physical issues, I no longer had the cognitive abilities to carry out my duties, and I had to accept medical retirement at the age of 49 on the direction of the work doctor. My recovery had become too slow and was stalling. Though I knew things weren't going as well as I had expected, having my job held open gave me a goal to aim for and allowed me to cling on to the hope that I may yet return to my pre-ICU life. Having that goal removed came as a huge psychological blow and brought the realisation that life was never going to be the same again. My medical retirement came into effect on the 4th of July 2011, my very own Independence Day, but there was no celebration. My near 30-year career in defence and intelligence was over. This brought financial implications as my work pension and disability payments fell short of my monthly salary. Yet I was still a single parent to 2 school-aged daughters and a baby to support, with the same household bills and mortgage payments to be met. Huge adjustments had to be made to my budgeting as I was the sole income stream to my household. Outside of my family, I lost the 2 big constants in my life, work and sport, having been a competitive track and field athlete my entire adult life. This impacted on my mental health and brought me into a continual battle with depression and troublesome thoughts, which last to this day. The financial worries just feed into and fuel this negative mindset. The ripple out effects go on and on. I learned that recovering from critical illness isn't just about the physical symptoms. The psychological recovery and cognitive recovery can be every bit as hard as the physical recovery, more so at times and often longer lasting. I always feel uncomfortable talking about the negative side of survival because due to the expertise, diligence and care of many doctors, nurses and physiotherapists in the Department of Critical Care at Gloucestershire Royal Hospital and the ECMO unit at Leicester Glenfield Hospital, I was able to come back from the edge of life and return home to my family. I am also very aware that there are many grieving families whose loved ones did not come home. But there is giving us back life, and there is giving us back life worth living. And those are two very distinct outcomes, in my opinion. Some may be happy to have the former, but I wanted the latter. And nearly 12 years later, I'm still not sure if that is what I have.
I appreciate that we are often very aware and very worried about post-ICU PTSD. I'm often told that we're giving sedation to make sure that patients don't suffer PTSD. We worry that they will have PTSD if we don't give sedation. And I think this has a lot to do with what we see when we take off sedation, when it's time to do an awakening trial and we peel back sedation, patients come out thrashing and agitated. What we don't often appreciate is that we're seeing delirium, and that delirium is a major risk factor for post-ICU PTSD. 1/3 of delirium survivors have PTSD 2 weeks after discharge. 1/5 still have it 1 year after discharge, and 1/5 of all ICU survivors. And what we need to appreciate is, again, what they experience when they're sedated and how that impacts them the rest of their lives.
Spencer Freeman. I'm diagnosed with severe chronic necrotizing pancreatitis, ETOH. I spent 5 weeks in ICU in a coma in 2016, and another 5 or so weeks learning how to live again, walk, talk, eat, all those kinds of things. I had a trach, a feeding tube, a PICC line, you name it. I mean, I really had everything. I suffered from sepsis, suffered from MARDS, all the kind of classic things that chronically ill people do. As well as delirium. But no one ever talked to me or my family about delirium. I didn't know what it was, and I didn't know that the thing I was experiencing had a name. It was only years later when I began to finally talk to my therapist about it after several years of goading. CBT, so cognitive behavioral therapy, and then dialectical behavior therapy, as well as exposure and EMDR. I was able to even address it and talk about it and acknowledge it. I thought I was going crazy. I thought there couldn't be an explanation for the fact that I time traveled, that I did things that were unmatchable. They were non-overlapping with what my reality was. So one either happened or didn't happen. But I was on all those medicines that caused the disassociation: ketamine, Dilaudid, Ativan, heavy sedation, propofol. But also my fever was incredibly high, and my body was going through a lot. So I experienced some pretty wild stuff. It was only later that I was able to get treatment and therapy for that. As I mentioned earlier, my therapist came up with the idea for the beard. It helps me with the nightmares that I have, which I still have to this day. Probably about half the times I go to sleep, I have a nightmare from the coma, and I need something to help me with that. So I take SSRIs and benzos. I do talk therapy. I'm a part of recovery groups. But I have to really work at what's real and what's not real 5 years on. I have scars all over the back of this hand. They're not from IVs. They're from me trying to rip out IVs. So probably about once or twice a week, I wake up with blood all over my hands. Try to pull off a ventilator mask. So this stuff sticks with me. It stays with me. And it is with me all the time. I have hallucinations and intrusions. So whenever my pain gets bad or my nausea gets bad, I see and hear things that aren't real, or are real but occurred to me at another place in another time. So it's hugely impactful on my life. I used to practice law. I can't really do that anymore. I used to work long hours. Obviously not possible anymore. So I have to take a lot of medicine and go to therapy twice a week, as well as these support groups, just to sort of maintain. Because if I didn't, it would probably lead to me getting myself in a situation like I did before, health-wise, or me not seeing another way out of this. So I'm very, very fortunate to have support mechanisms like this and like the talk therapy and like the support groups and a family that really understands that what I'm going through is very specific and very particular, and needs very specific and particular treatment.
I would invite you all to join survivor support groups on Facebook, or if you have any locally. I have learned so much from survivors. And when Spencer says if he didn't do all these things, he may not find another way out. In the 3 years that I've been part of these support groups, I've seen 2 survivors die from suicide. This is a very life-altering and even life-ending diagnosis. And we can do a lot on the ICU side to prevent these repercussions. But many may say, well, Kaylee, it's the ICU, it's life or death, and all we can focus on is keeping these patients alive. We feel really bad about the long-term cognitive impairments, the trauma, but we're just trying to keep them alive. That's all we can do. But if all we care about is mortality, that alone should make us panicked about delirium, because delirium is an independent risk factor for mortality. It doubles the risk of dying during admission. Patients are more likely to die 1 year after discharge. They're 3 times as likely to die within the first 6 months after discharge compared to those that did not have delirium. For every 1 day of delirium in the hospital, especially in the ICU, there is a 10% increased risk of death. This is a lethal brain dysfunction and failure. It also increases the length of stay. So delirium greatly impacts us as clinicians, as ICU teams. 1 episode of delirium can increase time in the ICU by 4.77 days and time in the hospital by 6.67 days. And I'll dive into an example of how that's happened on your unit. It increases time in the ventilator. It increases workplace violence. Raise your hand if you have been assaulted by a patient. Lower your hand if that patient did not have delirium. This is really dangerous to us when we take away their ability to understand what's going on. Now that you've heard it from survivors, it makes sense why they come out of sedation thrashing. If I thought my kids were kidnapped, there's no way you'd be keeping me in the bed. If I thought you were the one putting my child into a prostitution ring, which I've heard from a survivor, there's no way I'm going to be calm and compliant with you. We increase the risk to our clinicians. We increase the risk of line and tube removals. Delirium increases the chances of unplanned extubation by over 11 times. It increases healthcare costs by 39%, and it's a huge financial burden to our healthcare system as a whole, not just in the hospital, but long after. And it increases the workload. It can double the nursing hours required for care, and we're going to see in a minute how that happens. So even understanding that patients come with so many risk factors, we also need to understand our role in the development of delirium. Sedation is not sleep, and it's one of the biggest risk factors for delirium. It increases the risk of delirium by 8.5 times, especially depending on the type of sedation used, the dose, and the duration, the depth of the coma, and the duration of that sedation. So opioids, benzos, and propofol all disrupt sleep. They decrease stage 3 and stage 4 REM cycles. So essentially, they make actual restorative sleep impossible. Dexmedetomidine is the closest to sleep. And so when you look at EEG monitoring and looking for sleep patterns and sleep spindles, you do not see them with opioids, benzodiazepines, and propofol. You do see something kind of like unto it with dexmedetomidine. And this is why we see that dexmedetomidine has one of the lowest rates of delirium. It's still not something that we can keep patients on long term. And remembering that the goal of the ABCD of bundles have patients as awake, cognitively engaged, communicative, autonomous, mobile. We really want to minimize sedation, but this is one of the main reasons why, because sedation is the main modifiable risk factor for acute brain failure. So we look at the risks of delirium with sedation. Benzodiazepines are the main culprits or have the highest risk of delirium. Propofol also carries a high risk of delirium. Again, depends on the depth, duration, and dose. And dexmedetomidine has the lowest. And this is all likely rooted primarily in the sleep deprivation that delirium or that sedation causes. So looking at opioids, every equivalent of 10 milligrams of morphine increases the risk of delirium by 2.4%, which doesn't sound like much, right? But then if we look at fentanyl, which we're oftentimes automatically starting on every patient, even a low dose fentanyl drip of 75 mics per hour over 24 hours increases that risk of delirium by 72%. Benzodiazepines, like I said, are independent predictors of delirium, and they increase mortality. And this is likely why there's such a big contributor to mortality, because it increased delirium. When it comes to lorazepam, every 1 milligram increases the risk by delirium within the next 24 hours by 20%. And we're not often just giving 1 milligram in that 24.
Team, room 3206.
We're oftentimes giving about 1 or 2 milligrams, but then that chemically restrains patients for the next 4 hours or so. But when that Ativan wears off, they come out agitated again, oftentimes even more agitated, which makes sense when we understand that we've either caused or exacerbated and prolonged their delirium. And so we lock them into the roller coaster where we give them Ativan, they're restrained for a bit, they come out thrashing, and it's really hard when you put them on that roller coaster to then get them off. Midazolam is also an independent risk factor for delirium. For every 1 milligram, there's a 7 to 8% increased risk. So if you're giving a low dose midazolam infusion at 5 milligrams an hour, within 24 hours, that's 840% increased risk of delirium. That's why A-to-F bundle 101 is avoid benzodiazepines almost at all costs, right? Except for some rare exceptions. If you're having seizures, start with an Ativan bolus and then find other anti-seizure medications, right? But we should not be using benzodiazepines as chemical restraints for our patients. This is also why it is so important to really do our RASS scores accurately. Something that is misunderstood is that if our patients do not respond to voice, they are deeply sedated. But when we go to assess RASS, oftentimes we touch our patients and we say, hi, Betty, how are you? Right? We want to connect with them, so we touch them and talk to them. But if they barely respond with that touch, that does not mean that they're a -2 or a -1 on the RASS. That means that we don't know what their RASS is. So when you go to assess a RASS, do not touch them. Keep your hands to your side and just talk to them. If they do not respond to voice, they are deeply sedated. And deep sedation is an independent predictor of mortality. They're significantly at higher risk of dying if they do not respond to voice. And in addition, if they do not respond to voice, we can't do a CAM screening. We cannot test for delirium if they do not respond to voice. Technically, like on paper, it says that we can do a CAM at -3 and above, but at -3, they're barely opening their eyes to voice, and they're not making eye contact, and they're closing their eyes within less than 10 seconds. I think that's very difficult to get an accurate and thorough CAM assessment. So to really do a proper CAM assessment, I would suggest that we should have them at least at a -2 or higher. So be looking at how are we doing RASS, and if we're really assessing for delirium when we cannot actually arouse them. The only tools to prevent and treat delirium are sleep, family. So once that recent study showed that family presence for more than 2 hours a day decreased delirium by 80%. Mobility, active mobility outside the bed decreased delirium by 95%. Avoiding deliriogenic medications, and assessing for delirium. And the treatments are just the same: sleep, family, mobility, addressing the cause of delirium. So delirium, we need to understand, can also be a warning sign. When we have a change in mental status and we have acute onset of delirium, that tells us something is wrong, something has changed. Sometimes that's one of the first signs of an acute onset of an infection. But when we have our patients sedated, deeply sedated, and we cannot assess for a CAM, we cannot assess for delirium, we don't know if they've had changes. We don't know if they're having acute brain failure right under our eyes, and oftentimes from our care. And so if we continue to sedate them, oftentimes in response to the agitation, right? If we do an awakening trial and the patient comes out agitated and we resume sedation, we're not able to treat delirium because we're continuing to give what might likely be the very cause of the delirium. I would suggest that giving sedation in response to delirium is like giving bacteria in response to sepsis. It does not make sense, and it's not safe for our patients. And we'll get into how that also impacts us as clinicians. So when we automatically sedate our patients without assessing whether or not there's an indication for sedation, when we continue sedation, we take away the very tools that we need in order to prevent and treat this organ dysfunction and save patients' lives and preserve their quality of life after the ICU. So when we roll out the ABCDF bundle, what often happens is we start with assess, prevent, and treat pain, but that turns into starting fentanyl automatically. And then we end up just starting sedation automatically because that's what we know, that's what's familiar, that's our routine. But when we do that, we take away all the other tools. We can't truly prevent or treat delirium. We can't truly mobilize them, and therefore can't have all the tools to treat and prevent delirium. They can't really engage with their families. So when we're looking at an 8F bundle culture within our ICU, I would invite you to see it more like an F to A bundle. If we prioritize family, if our goal is to have them really engaged with their family members, communicating with them, writing on a clipboard, connecting with them, that will influence our sedation practices more than anything else. If we want them to communicate and have their autonomy and connect with their families, we will not automatically start sedation. And when they are awake enough to do that, they're ready to mobilize. They can actually mobilize promptly. And therefore, we can greatly prevent the development of delirium. And then D actually happens. And then C comes into play when there is an indication for sedation. So if someone has intracranial hypertension, seizures, if they are unable to oxygenate with movement and we're stuck, we have to sedate them. Then we're going to be looking at, okay, we have this indication. What's the safest sedative? We're not going to go to benzodiazepines right away. We're going to look at, could we get away with dexmedetomidine? If they have to be deeply sedated, let's do propofol. But what's the lowest dose and the shortest duration? We're going to reassess every shift, every round. Do they still have an indication for sedation? What are their intracranial pressures doing? Are they still having seizures? Okay, if not, if those pressures are within reason, if this acute problem is resolving, let's do a trial. Let's see, do they stay physiologically stable when we take sedation off? Okay, great. Now we don't need it anymore. Now let's rehabilitate them. Let's treat the delirium. Let's mobilize them, right? That's how we really implement the C. And part of that, so once we see that they don't have an indication anymore, then we're going to do awakening trials. Awakening trials should be done not just at the end of critical illness. They're not just for extubation. Awakening trials should be happening when there's no longer an indication for sedation. They're most easily done shortly after intubation. That was my experience in an awake and walking ICU. Is we would intubate patients, sedate them for the procedure, use procedural medications, and then ask, do they have an indication for sedation? In this medical surgical ICU, even during COVID, it was not that common that patients had an indication for sedation because mechanical ventilation is not an indication for sedation. So then you allow them to wake up after intubation. Now, if you're using paralytics, you may need to have something going for the first hour or two, and then reassess again. Do they have an indication for sedation? Letting someone come out of sedation, induction meds, or short-term propofol is very different than how they come out of long-term or prolonged sedation after days to weeks, and they've developed delirium and they're lost and they think the worst things are happening to them and they're panicked. They're really difficult, as we've all experienced, to manage, to keep safe, to prevent unplanned extubations, to keep you as a clinician safe. It's really difficult. When that's our approach, it's really hard to really master the ABCDF bundle. It's really hard to go from that to then awake, writing on a clipboard, walking. But we're more likely to have most of our patients that way if we really assess at the very beginning, do they have an indication for sedation? Is it worth starting these deliriogenic, these neurotoxic medications? Do they actually have to have that? Or can we let them wake up and still have their coping mechanisms with them? Can we reorient them, have them talk to their family, give them a clipboard, their cell phones to communicate? Can we treat their pain with some boluses of fentanyl and therefore help prevent and treat agitation and pain? That is how we make this sustainable and feasible, not just automatically starting sedation, then taking off later, unmasking the delirium that we've caused, and leaving the nurses to deal with it on their own. I've experienced that, and I'm adamantly against that because it's not safe for our patients, our clinicians, and it's not sustainable. But that's not what we're working towards. We're working towards really preventing delirium and really making this safer for everyone involved. So we need to look at, again, family, really connecting with our family members, mobilizing as soon as possible unless there's a contraindication to mobility. And this approach, what I'm explaining, is oftentimes not practiced, not what's understood throughout the community. So I really want to talk to you about a case, an example that's happened on your unit. And this example is something that you could see in many ICUs. This is not unique to your ICU. This isn't one person's problem. This is everyone throughout the ICU, not everyone, but most teams are kind of stuck in this situation. And I want to show how this increases the workload for you as clinicians and the danger to our patients. So this is a 54-year-old ambulatory woman with a history of methamphetamine abuse, which we can all appreciate can be very difficult patients to take care of. She requested while in the ER to be intubated for hypoxic acute respiratory failure. She had strep pneumonia, bacteremia, and septic shock. So that was on June 17th. On June 18th, I saw in one of the provider notes that they speculated that the hypotension she was having, the vasopressor need, was more related to sedation because her sepsis was improving. She didn't seem to be in shock anymore. And the goal was to do an SAT SBT the next day. I could not find any documentation of an SAT or SBT being done until the 21st. And when they did SAT SBT, the SBT went well. She was able to breathe independently, but it was noted that she was too encephalopathic to extubate. Of course, I wasn't there, but understanding that she had lots of risks for delirium, right? She probably had some withdrawals. She had sepsis. She was intubated. She was sedated. So encephalopathic may be delirium. She's probably too delirious to extubate, which obviously we want our patients following commands and things like that to extubate, but sedation was resumed. So we need to look at, again, why was sedation resumed? What was the indication for sedation? Is a failed breathing trial or failed awakening trial an indication for sedation? If she was agitated, were we really treating her agitation? What was the agitation from? Was it from delirium? And resuming the sedation was likely to only exacerbate and prolong that delirium. Well, that propofol was continued until the 26th. That's 5 more days. And during that time, she developed a new deep tissue injury to her coccyx and buttocks. On the 22nd, there was a breathing trial report, the same, too encephalopathic to extubate. Finally, on the 26th, fortunately, she was able to be extubated to high flow nasal cannula, likely because she had some weakness, which we'll talk about next webinar, about how the whole respiratory system is impacted by sedation and immobility. And she remained in the hospital until July 4th. She basically left AMA, but she discharged with significant cognitive and physical impairment, such as balance issues, weakness, gait deficits. Looking at her just on paper, she's at high risk of being readmitted to the hospital. So theoretically, if she was intubated just for septic shock at the time, and strep pneumonia, but she passed her breathing trial, she was on minimal ventilator settings, the 18th and 19th, she likely should have been extubated on the 19th. But let's look at her sedation. So propofol was started upon intubation automatically, and started at 40 mg per kg per minute upon intubation, and consistently remained about 30 to 40 mg from the 18th to the 24th. So looking back, there was no decrease or real cessation of that propofol as there likely should have been. It was a true awakening breathing trial if we were really working towards the goals of the bundle, which is to have patients awake, mobile, engaged, autonomous, all those things, right? But then on the 24th, propofol was increased to 50 mg per kg per minute until the 26th, which is a really high dose of propofol. Now, fentanyl was at 25 to 50 mics per hour from the 18th to the 22nd. On the 22nd, it increased to 100 to 150 mics per hour. And again, I wasn't there. I would speculate that maybe she developed some tolerance. She might be a quick metabolizer, but also she likely was having more agitation. That her delirium was worsening, is becoming more profound. Sometimes this could be provider dependent. Because our RAS scores are sometimes very variable, very subjective, depending on the provider. Sometimes doses increase because that might be a preference from a clinician. In addition to these continuous infusions, she was also getting midazolam boluses. So on the 18th, she got 1 milligram bolus. On the 21st, she got 4 milligrams. These are total accumulation of boluses. But even on the 24th, she got 10 milligrams. And she was also getting oxycodone down her feeding tube at 20 to 40 milligrams each day. But looking at what was her real indication for being intubated, why did she require mechanical ventilation? She had respiratory failure from strep pneumonia and septic shock. Those likely resolved around the 19th or 20th. I'm speculating, right? She could have passed the breathing trial, but it was her brain that was keeping her ventilated. But instead of treating the acute brain failure, we continued medications that exacerbated and prolonged that acute brain failure. And looking at what this means for your team, not only for this patient, obviously her life may never be the same again. And it sounds like she had some difficult psychosocial problems beforehand. But looking at your team's workload, your team probably treated her on mechanical ventilation for 6 or 7 extra days. That's a lot of work. Sometimes we perceive sedation as being easier. It's easier to just have them still not moving a muscle, not having to worry about them, turning them every 2 hours, whatever. But you were also running vasopressors, which probably would have been avoided or at least minimized without the sedation. That's another whole drip or 2 to run. Those are 2 extra intravenous drips to be running, to be scanning in, to be wasting together, to be checking, to be documenting. Restraints are a lot to document. I mean, this is turning every 2 hours, then treating a deep tissue injury. That's a whole nother expense and workload. This is a lot of work that could have been avoided if she had been awake promptly. She'd only been sedated if there's an indication for sedation, which I would speculate I don't see. Unless she couldn't oxygenate with movement, she probably could have and should have been awake and mobile promptly after intubation within the first 24 hours. So this was not the best evidence-based practices in general, but also, again, very laborious and very burdensome for your team as well as for the patient the rest of her life. There's also very minimal delirium screening. There was a lot of unable to assess. So I would look at that too. A lot of times RAS scores are charted at -2, -3, maybe -1, but there's an unable to assess. So either sometimes I see that nurses are taught or believe that they can't assess for delirium or can't use the CAMS tool for patients that are intubated, but this tool is created for nonverbal communication. So that's one of the causes for unable to assess, or that she was sedated more deeply than the reality of the RAS documentation. So instead of being a -2, she was perhaps a -4, -5, which is probable at a propofol of 50. So unable to assess, though, she went a long time without being screened for acute brain failure. And then she did not receive mobility until the 28th. Again, she was admitted on the 18th, and she did not have any mobility up until the 28th. And then finally on the 29th, she was on her feet with some ambulation. That is extremely impactful, especially with someone that probably has poor support system at home. We need to be looking at what happens after the ICU, and we'll get into that next presentation. And then there was some documentation of the ADF bundle education to family and medical updates, but she was not really able to engage with her family because she was sedated. So again, this scenario could happen in most ICUs right now, but that doesn't mean that this is what we're striving for. We need to be really looking at how to prevent and treat that brain failure. She likely had untreated brain failure for 8 days. It costs over 5 days of mechanical ventilation and significant extra days on the medical floor as well for rehabilitation. And we don't know, but she, again, was at high risk of being readmitted to the hospital, especially with that deep tissue injury. She's likely to have an infection from that, especially considering her history. So this is going to set our whole teams up for poor bed flow, more workload, more burnout. You are working so hard to provide care for these patients, but you're deprived of the opportunity to see someone like this be calm, be themselves, walk out the doors, and succeed. Again, it could have decreased her length of stay by 7 to 14 days if she was mobilized, and it certainly would have prevented the deep tissue injury. Here's an example from a team I recently worked with a similar patient, because we're all always struggling with substance abusers. And they're always going to be present in our ICUs and at increasing rates. But sometimes we label them and we dismiss them as appropriate for the bundle. Like they have to be sedated because they're substance abusers. So I was working with a team about a month or two ago and saw a patient that was intubated and sedated. He was on, similarly, 50 mics of propofol. And I asked what was going on. He was 32 years old. He was obese, probably somewhere between 300 and 350 pounds, had a large abdomen, and he had a history of opioid and benzodiazepine abuse. He was found down in a hotel room from an overdose with aspiration. He was admitted to ICU and intubated on a Wednesday night. Overnight, he was agitated. So he got Versed boluses, and propofol was increased to 50 mics per kg per minute. He had high ventilator settings. He was on assist control of PEEPA 16. His FiO2 was, sorry, that should have been SpO2. SpO2 was 90 to 100%. His SpO2 was about 91%. His lungs were full of aspiration, and he was at high risk of developing ARDS. And so I had really had to ask some probing questions, because they saw a substance abuser that was likely to be agitated, cause harm to himself, harm to the clinicians. But I wanted to know, why was he agitated? I saw him on this crossroads. As an obese male, he was at high risk of losing lots of muscle really quickly. Obese patients lose muscle first. He was at high risk of severe delirium. If he developed delirium and ICU-acquired weakness, he was going to be really dangerous for the clinicians to try to turn, to move. He was going to be difficult to mobilize later. He was going to be dependent on the ventilator for a long time. This was going to create a lot of work and risk for their team if they didn't just nip this in the bud and prevent and treat delirium and ICU-acquired weakness. So I asked questions that I thought, why do you think he's agitated? Well, he wasn't on any opioids, and he's an opioid abuser. So we started oxycodone and Klonopin down his feeding tube to treat his withdrawal. Then we turned the propofol off. Well, he remained a RAS of -5 for another 6 hours. All that propofol had settled into his adipose tissues, and he didn't arouse for 6 hours. When we came in the morning, he was probably RAS of 0 + 1. And so PT and OT sat him up at the side of the bed, and you could just see he was grumpy beforehand. You could see everything just kind of melt off. He suddenly, I'm sure he could breathe better. His sats were about 89, 90% on those high settings while laying in bed. When we sat him up, he went up to 93, 94%. They got him to the chair, and he sat there right on the clipboard and was calm, unrestrained the entire weekend. On Monday, he was extubated and walking laps around the halls. So he went from a PEEPA 16 and 100% to, on a Friday, to walking around the halls extubated on a Monday. Had he been sedated and immobilized and developed delirium, and every time they turned down sedation, he came out thrashing and they resumed sedation, he likely would have been sedated and immobilized for at least days to weeks longer, and would have had a really difficult course for everyone involved. The ADF bundle saved his life and preserved his quality of life and his cognition. He's going to have a better chance of rehabilitating from his substance abuse as we minimize his trauma and preserve his cognitive function and his physical function as well. So looking at our screening, our protocols, this is just a general ICU liberation protocol. We need to be looking after every intubation. Do they have an indication for sedation? Now, when they have agitation coming out of sedation, we need to be looking at what is the cause of the agitation and be treating the cause. And I've provided you guys an agitation toolkit to help guide you through how to assess and treat for agitation. But when we have a failed breathing trial, that doesn't mean that sedation is resumed. You obviously have to be awake to do a breathing trial, but you don't have to be doing a breathing trial to do an awakening trial. We need to be taking off sedation as soon as there's no indication for sedation. So when it comes to agitation, and this is one of our barriers to avoiding sedation, if someone's a RAS +1 or +2, they're fidgety, they're kind of pulling at, they have active psychomotor activity, they're not dangerous yet. That we have time, we can establish communication, ask them, do you have pain? Are you scared? Do you want to write on a clipboard? Connect with them, figure out if they can tell us what the cause of that agitation is. If they have, and then you evaluate. So second step is evaluate for cause of agitation. Third step is address the agitation, treat the pain, and then reevaluate. There may be multiple causes. Sometimes patients come out of sedation and they need to use the bedpan. They're trying to tell you that they need to have a bowel movement. And they might have pain. So as we treat different causes that we're able to identify, we need to reevaluate. But if they are a RAS of +3 or +4, and they're starting to pull at the restraints, try to self-extubate, try to hit clinicians, that's not the time to sit there and hold their hand and have some therapeutic communication, right? That is an indication for sedation, a RAS of +3 or +4. Sometimes we call a RAS of +1 agitation. That's not agitation. We need to look at what is and what is not dangerous behavior. +3 and +4, that's dangerous behavior. That's when we need to be using maybe some chemical restraints like dexmedetomidine, low-dose propofol, to get them into a safer zone, to get them closer to a RAS of 0 or maybe even +1, and then circle back to these steps. Be looking at, okay, what's actually causing this? Is it delirium? Okay, then continuing this propofol is not going to help delirium, but let's mobilize them. Let's actually treat them. Here's an example of that, and then let's get to questions and answers and chat. Megan Wakely was a 32-year-old with a history of alcohol and benzodiazepine dependence and marijuana use. She had malnutrition. She had a lot of baseline trauma throughout her life, and which led her to have this alcohol and benzodiazepine dependence. She was admitted to an outside facility for alcoholic leukopenic pneumococcal sepsis, so ALPS. She was at the end of alcohol withdrawal when she showed up. She was in septic shock. She was in severe respiratory failure. She was intubated and on high ventilator settings. And she remained sedated and immobilized for 7 or 8 days in this outside facility. And her lungs were getting worse. Her sepsis continued, or she was still on vasopressors at least. And they started to prepare the family to transition to comfort measures. The family decided to have her flown out to the awake and walking ICU. And upon arrival, she was on a PEEP of 14 and 80%. She was on a Versed drip, fentanyl drip, and she was deeply sedated. So we had to look at, okay, is she oxygenating on these current ventilator settings? And she was on, I think, 1 vasopressor. So is she hemodynamically stable on those vasopressors? Okay, now we know that she's stabilized where she's at. Now we need to zoom out, look at the bigger picture. She has lots of risk factors for delirium. Alcohol withdrawal, sepsis, sedation, benzodiazepines, withdrawal. Like she's had probably terrible delirium. We didn't look at her. This is a picture of her later on, but at the time she didn't have her dog. She couldn't move her legs. But we didn't look at her and say, okay, she's sleeping and she's safe. We were concerned. We said, wow, she's likely having acute brain failure. And if we continue this, her lungs likely won't get better. She needs to mobilize for her lungs, and she needs to mobilize for her brain and her entire body. Her survival and her quality of life depend on her getting out of bed as soon as possible. So we turned down sedation, and it was just as bad as you would anticipate. She was a RAS of 3 or 4. She actually bit through her endotracheal tube, which I had never seen before. The severity of delirium is really different when patients come from outside facilities versus when they develop delirium from just an ICU stay or maybe like sepsis in that ICU. Patients still can develop delirium, but the severity is totally different. So I'd never seen a patient bite through the endotracheal tube, which obviously was an emergency. So we resedated her, did a tube exchange, and we had to really regroup and say, well, what are we going to do? We didn't just chalk that up to a failed awakening trial. We said, okay, she has really concerning signs of delirium. She's in severe brain failure and she has baseline trauma. What is going through her mind? How do we get her back into reality to minimize that trauma, to help her know that she's safe with family, that she's safe with clinicians, that nothing bad is happening to her? So we transitioned where we had to look at what are the causes of delirium or of the agitation, right? She's a benzodiazepine dependent person. She's been on benzodiazepines. We didn't want to abruptly stop that. So we started Klonopin down the feeding tube to cover for benzodiazepine dependence and avoid withdrawal. We kept her fentanyl going to treat pain. Now we needed to treat delirium. So we transitioned to propofol and Precedex with the goal of just having Precedex going. So eventually we had her just on Precedex. This is all within like an hour or two. Just had her on Precedex, and she was awake to a RAS of 0 + 1, and we got her up and started walking her. And I remember she'd been immobilized for 8 days. She was weak. She was delirious. It wasn't pretty. This video is probably her second or third session walking.
There you go. Look at your stats. Good job. You're doing good.
Now, keep in mind, this looks like a huge entourage, and it was initially, but we have 2 family members. We have a respiratory therapy student and his supervisor observing him, right? So she did need some extra assistance than most patients because she was so weak. But we also had extra people there because the family was really involved, which they should be, right? But it's not that this took 5-10 clinicians. It's just that we had some extra people on that day, or family available. And it was probably her 3rd walk or so that she finally woke up. She told me in a podcast interview that she woke up walking. That's when she realized that she was in the hospital, that she was intubated, and that her sister was there. And we gave her a clipboard and she started writing. And her first question was, "Where is my daughter?" That was her very first question. Can you imagine? We heard from a survivor talking about he thought his children were kidnapped. If you couldn't communicate that and couldn't be assured and have everyone around you know that that's what you're worried about, you didn't know if your kids were safe, there's no way you'd be able to calm down. But we were able to answer where her daughter was, where her dog was, and she calmed down. And even though her lungs, she developed cavitary pneumonia, her lungs were really sick, really fibrotic. So she ended up on a PEEP of 18 and 100%. Her delirium got better. She started to sleep. So after that first walk, she was so exhausted, she slept. That is one of the best ways to wear patients out and have them sleep and be calm, is to mobilize them. And it works like a charm. Then we asked, does she still need this Precedex? She didn't, so we took it off. But when she would come out of naps or after sleeping, she would be anxious again. Again, never a RASS of 3 or 4, but she'd be anxious. And so we'd get her up and walk her again. She'd walk 3 times a day. She'd sleep, walk. And so after about 24 to 48 hours, she was free of delirium. She's unrestrained. This is her with a PEEP of 18 and 100%. After over 3 weeks of mechanical ventilation, she walked out of there independently breathing. And this is the true A to F bundle. We need to really look at what is the reality of the sedation we're giving? What is the patient's perspective in all of this? And what do we want to happen to them in the next few days, weeks, years, and the rest of their lives? And we can have a lot of impact on our delirium within our ICUs. The A to F bundle, even at lower compliance, decreases delirium by 25 to 50%. And I'm excited to answer any questions about this. Oh, Daniel mentioned that we use Riker. Sorry. So when I talk about RASS, I'm really meaning the Riker. So our scale or our measurement of depth of sedation, I meant to put in the Riker scale. What questions do you have or thoughts?
Kaylee, thanks for highlighting that case. I think that was really meaningful for a lot of us to see that. I can recall that patient just from an educator perspective. Does anyone have any questions for Kaylee?
How did the last presentation impact what's happening on the floor since last time we met? Have you seen any changes? Even if it's just in your own perspective.
Has anyone noticed any change at all? ICU with patients? We don't have a lot of ICU nurses here. It's mostly physical therapists today.
Okay.
Our ICU has been pretty busy with a lot of high acuity patients, and we've been fairly short staffed, so a lot of people are currently working or working last night or tonight.
Kaylee, I have a question.
Yeah.
So you've got this lady who was delirious for a long time, and you want to get her up, but she's probably not cooperating and following commands.
Yep.
What do you do?
So do you guys use the BMAT?
No, what's that?
Okay, it's a mobility screen tool. It's really not specialized for the ICU. It's just what a lot of hospitals are using. Part of the assessment is whether or not they can follow commands, and that's why I'm concerned about it being used in the ICU. There is a perception that patients have to be following commands to mobilize, which is really concerning, because if one of the reasons you can't follow commands is delirium, but one of the main tools to treat delirium is mobility, then we're really stuck, and we're going to have patients just writhing in their beds trying to pull at things for forever, right? So you also can't mobilize someone that's a RASS of +3 or +4. I think even +2 is kind of pushing it, right? So looking at I'm talking about RAS again. What is their Riker score? So PTs and OTs, if you don't know what the Riker score is, go learn it. That I want everyone to know what the Riker score is and be talking that same language and say, hey, they're not answering to voice. I'm concerned about their Riker score. I can't mobilize them because their Riker score is blank. Or when we do an awakening trial and their Riker score is blank, we can't mobilize them because they're so agitated, they're dangerous, right? So ICU liberation, Society of Critical Care ICU liberation protocol says when we do awakening trials, we should turn sedation off. And if they are dangerous, so high Riker score, trying to pull at lines or tubes or hurt themselves or others, then we resume sedation, but at half. We don't just resume sedation and increase it. So when it comes to awakening trials, we see different outcomes in different studies. It's because we do awakening trials different on different teams. One study looked at awakening trials in the form that many of our teams are doing, which means you turn off sedation and you see them thrash and you turn it back on. That's how I was taught to do awakening trials. When that happens, oftentimes the sedation increases and goes higher. So in this one study, they were repeating a study that had been done, but they had completely different outcomes, and they found that their patients actually had higher cumulative doses of midazolam in the awakening trial group versus the control group. And it was more work for the nurses. But it's because they didn't work towards sedation cessation. They just resumed the sedation. They wanted to get them deeply sedated again. They want to get them back to the point where they were totally controlled and not moving and not awake, not opening their eyes at all. But that's not what we're working towards. We're working towards sedation cessation, but sometimes it might require us to resume it, but at half. And again, we're trying to get them as awake as possible so they can mobilize, but not dangerous, not thrashing, right? That's where you guys as physical and occupational therapists can be so powerful. When someone is sedated and you see that their awakening trial failed, please go in and ask them what happened during the awakening trial. Now, if they said, I just heard from the night shift that they were agitated, say, what was their Riker score when that happened? That gives you a heads up of what are they likely going to be like again. So a lot of times we're doing daily awakening trials and that's it. But if they don't have an indication for sedation and they failed an awakening trial, then let's revisit this and say, okay, so they came out agitated. Why were they agitated? Did they have delirium? Can I help with that? So let's take it off. If they come out dangerous, turn it on at half, then let's sit them up. So when someone's laying in bed and they're not following commands, that doesn't mean that they can't mobilize. It means that you need to progress carefully, right? If you don't know what they're capable of yet, what oftentimes happens is whether they're kind of wiggly or they're kind of sluggish. When you sit them up at the side of the bed, the lights start to turn on. They start to open their eyes more. They start to make eye contact. They start to follow commands. They start to calm down. They start to engage with their environment. Have their family members right there in front of them. While they're sitting up, let them hug their family members if they're strong enough to, right? Let them come back to reality. Then they're likely to start walking. So Megan Wakely, it wasn't just pop out of bed right away. It was, let's sit her up. She's on Precedex, but let's sit her up and see what she does. And she was still delirious. Even those first 2 walks, she was so delirious. But walking is as innate for most of us as breathing. So a patient can think that they're on Mars, but you get them on their feet and they just start walking. But you don't know until you get there, right? That doesn't mean that you throw some out of bed when they are unable to lift their legs. So that's why mobility screening tools are really important, but we need to also critically think through those and say, are they unable to follow commands because they're delirious? Then let's try to clear out the delirium. Let's do lower levels of mobility and see if they start to engage more. Does that make sense?
So
yeah.
When you are turning down the sedation and you're getting them up for the first time, is your rehab team in there every time, or is it the nursing team that's in there first and then the rehab's coming later?
For the initial awakening trial.
Mm-hmm.
So, the approach that my teams are taking now is to turn sedation off ASAP. So that doesn't require PT or OT to be there. Now, if someone maybe has been prone to paralyze and they've been sedated for a long time and they've had awakening trials go wrong. I mean, just be poor, right? Because they're so delirious. That's when I'm going to be looking, as a nurse practitioner, as a nurse, I'm going to be saying, okay, I heard that those didn't go well. I'll bet I need more help. My goal is to get them awake and rehabilitate them from delirium. And they're likely to be really weak because they've been sedated for so long. So now I'm going to make sure I have the right people in there with me. I'm also seeing, think of the episode. I did an episode with an occupational therapist who took a really big role in her team rolling this out. And before, it was her going around room to room saying, hey, can we take sedation off? Hey, can we take sedation off? And it was just a waste of time, right? And it was really laborious. And now, after a few months of implementing this, after we did some training with them, now they're coming to her saying, hey, I've got a patient that's delirious. Can you come help me? Hey, can you come into this room? I've already got them on the side of the bed, but I just need some more help walking them. Like nurses are already doing as much as they can, but patients are already awake, responding, ready to go. Or if they've had a bad awakening trial, they're knowing how to utilize the PT and OT. But I also think it's a skill set for the PT and OT as well, right? I don't know if you know Christiane Perme. She's really well known in the ICPT world, but she says it's amazing that physical therapy is the only occupation where you can graduate on a Friday and be in the ICU on a Monday. So if you haven't taken her course, or if you haven't mobilized patients on ventilators, I really invite you to take her course and to learn a lot of the line tube management, and then study more about this delirium. I'll send you guys some episodes to listen to talk about how you as a PT and or OT can help nurses during awakening trials, where we've been so siloed, right? And nurses have been left alone with the sedation management and the awakening trials and the delirium stuff, that it actually causes more of a barrier and a wall for you to be able to get in and get your job done. So what we're wanting to do is help the nurses understand that you're there to help them, that mobility is also their job, that you can be more involved with them when they're more awake. But if they're having a hard time getting sedation off, that you're you're the SWAT team. You were the delirium SWAT team. So I remember when COVID hit and I had a float nurse come into our unit, she blocked the door to the PT and said, no, they're too confused. They can't mobilize. They're too confused. And the physical therapist came to me looking like she'd seen a ghost. And she's like, I've never heard that before. Because I am the treatment. If they are too confused, if they're delirious, I am the delirium SWAT team. It's time for me to come in and work with them. So this is why we all have to understand delirium and understand how to treat it and be able to really assess it and finesse all these little tuning things within our patients, because not every patient is the same. But right now, we've really treated every patient the same. We've had this conveyor belt going of intubate, sedate, turn Q2, like really things are predictable. But it's going to take everyone to make this happen, to be able to say, what is the best for this patient? How do we truly prevent delirium and therefore make everyone's job easier? It's not easy to mobilize someone after they've been sedated because of the weakness and the delirium. It's going to make your job easier. It's going to make the nurse's job easier. But everyone's going to need to have some easy success stories to really experience that. So my best suggestion is to find patients that are going to be easy wins, a few, right? Get your physicians in on this. Say, hey, this patient is admitted for pneumonia, for a COPD exacerbation or something, right? Don't do your like polysubstance abusers right away that are going to have withdrawal, which it seems like every time I go to a team, that's what we end up doing, and it works. But I would just suggest if you're doing this, trying to navigate this on your own, find someone that's going to be easier, but get sedation off right away, get them up right away, take pictures of it, get your patient authorization forms ready, have patients sign permission to take their pictures, and then share that with your team and say, look how great this turned out. They were awake, they were calm, they were compliant. And point out it's because we took sedation off right away. We prevented delirium. They were able to walk around the unit with 2 or 3 people because they were not so weak from sedation and mobility. Like play out the why as well, but let your team see what it's like and experience that. Because then when you could go back to the patients with a normal process of care, you're going to be frustrated. You're going to realize how much more work it is, how much harder it is, and how poor the outcomes are. And you're going to start to experience that contrast. And this won't be seen as an acceptable norm anymore. Any other questions? Yeah.
So certainly it's going to take a unified approach for all of us to make this change and actually have an impact on how we can do better with this. And we're having all the ICU nurses just be raised awareness by watching these webinars, and the intensivist, PT, RT, everyone who touches these patients at the bedside is going to be on the same page whenever it comes to mobilizing these patients. It's really going to take changes from each of us to advocate for getting these patients up and out of bed and lightning sedation, and actually following the protocol for assessing delirium, and when we do those awakening trials, having the sedation, getting it off as soon as possible.
We've been just so siloed. I've just seen pharmacists look at me with pure panic when I say, hey, you need to be asking, is there an indication for sedation? And they say, I can't talk about that. I can't bring that up. And I'm like, well, why not? You are the steward of antibiotic use. You need to be the steward of sedation use too. You would never let us give an antibiotic without an indication. Why would you let us give something so dangerous as sedation without an indication? So we need to break down these walls of these territories to say mobility is just PT and OT's thing. Sedation is just nursing's thing. Delirium assessment is just nursing's thing. But everyone needs to scratch each other's backs. So when you see a patient that's sedated, as therapists, you can ask, is there an indication for sedation? Can I help you get it off? None of this needs to be combative or accusatory, but just help me understand how I can help this patient. If there's a real need for this patient to be deeply sedated, then yeah, not appropriate for me to work with them right now. But if there's not, then let's mobilize them. Let me help you, right? I will, just since you're mostly therapists here, I will say too, a great way to get buy-in from the nurses is to help them see that you're incorporating some of these tasks into their ADLs or into their therapy sessions. So when I see a physical therapist getting my intubated patient up to the toilet, it's part of the therapy session, right? It's an activity, it's part of ADL, things like that. But that made my job easier. Or they're helping keep the lines and tubes intact and in order after a therapy session. Like little things like that are not so little to nurses. They need to understand that you're there to help their jobs, to help their patients. They also need some time to understand that you're safe with their patients. If you haven't had a huge culture of mobility, they may feel very protective of their patients. They're afraid of mobility. Just embrace that, just understand that and work with it and explain that it's safe, help them understand what you're doing, help teach the nurses what you're doing so that they can have those same skills to mobilize their patients, because you're not the only ones that are going to be mobilizing patients. That's not what we're working towards here, right? But they also need the training and the kind of skills that you've developed. It's not so easy for them when they haven't been taught how to mobilize patients. They're scared. So hold their hands as you do it. Talk out loud, explain to them why you're doing it, help them see that you're helping them too. I've had, PTs help me boost patients, wipe butts, like not that you're having to do that all the time, but those little things helps everyone feel like they're a team. And that's what we're building here. And so you can ask, why are they intubated, or why are they stated? Why is their Riker score this? I noticed that they're CAM positive. I'm really concerned. Bring those things out in the discussions. And I would invite you to listen to episode 131 of the podcast. It's with an occupational therapist. 131, and the most recent episode, 154. So one's with an OT, one's with PT, talking about how to really help with this agitation, this delirium, but how to be leaders of all of this, because I think therapists can play a huge role in helping the nurses and physicians tie the ABCDF bundle together.
I think you nailed it regarding our current culture. When we first started asking those questions, like what is their Riker, what was their sedation vacation actually like, people are going to get defensive, and that's fine. Like we have to get past that. We just have to normalize that this is what we're going to be doing. Those are the questions that need to be asked so that we can highlight it and actually make progress.
And this is why I'm really passionate about this education. I think we expect nurses to really understand the delirium because they're managing the sedation, but they don't. I did not know this information for the first 7 years of my career. And I was the one titrating the sedation when I was a travel nurse. But I didn't know that delirium doubled the risk of my patient dying, or that if they were deeply sedated, they were significantly at greater risk of dying. Like I didn't know that. So don't assume anyone's intent on anything. It's not because anyone's lazy or don't care about their patients. Oftentimes it's because they don't know this yet and they're not comfortable. And that's going to take time and education. So if you're having a hard time, see if they've really understood this information. I can give you guys like a cheat sheet, things to bring up in rounds, information to share, reaffirm. Once everyone understands the why, then you can work together to find the how. So,
Thank you, Kaylee. Does
Yep.
anyone have any other questions?
okay, we'll see you next time. Thanks so much, everybody.
Thank you.
Thank you.
Bye.